but whether you're healthy or unhealthy, PBM is still very helpful. But there are certain things which will hinder your ability to heal. And this is where, within the context of healing and repair, it helps if you just understand that, you need to have basically a healthy body. You need to have a good diet. You need to make sure there's a good blood supply there, that the wound is stable. You're not going to damage it and let it get infected, and that there are other factors there which medically may make it more difficult for you to heal and repair. And if you understand that, then you can start to appreciate the limits of what you might be reasonably expected to be able to achieve. Because for some conditions, it's like magic. You've got someone who's healthy, who's got a sports injury, they do some PBM, and hey, they recover really fast. Whereas if you're ill, maybe you've had some cancer chemotherapy and radiotherapy, you're not so good, it's going to take longer, and it's a more arduous route, and you can't expect to see instant results.
Hey, this is Ari. Welcome back to the Energy Blueprint podcast. With me today for, I don't know if this is round 3 or 4 or 5, it's hard to keep track of it at this point, is Dr. Mark Cronshaw, who is one of the top experts in photobiomodulation, the science of how light interacts with human biology. This is a very, very deep dive into the science of PBM, of photobiomodulation. And we get into a lot of different areas related to dosing, related to controversial, contentious topics, where there are disagreement among experts, all kinds of things. It's this continuation of the previous conversations that we've already had, the 2 episodes or 3 episodes that I've already released on this, on the topic of PBM with Dr. Cronshaw. So if you have listened to those, you know that this is very geeky, very sciencey stuff, at times somewhat technical stuff. So keep that in mind. 2 things. Let me be very clear about this. Number 1, if you haven't already, make sure to listen to the earlier podcasts with Dr. Cronshaw. That will be very important background before you get into this conversation. And the other thing is, again, just a warning, this is very technical, geeky stuff. If you don't care, and probably a lot of you don't care to get into the real nitty-gritty of PBM science, you want maybe something more simple, here's a few mechanisms of how it works, go buy this device, sit in this position and, apply it in this way for 5 or 10 minutes. That's not what this is. This is a very, very deep dive into the science of how this is working, and a lot of complex, controversial, nuanced issues related to what it does and how to best use it to get the best results, and how it's working, and so on. So if you do want a very high-level discussion of PBM science, I think you're absolutely going to love this continuing conversation with Dr. Cronshaw. I've personally learned a lot from him. I've had many hours of conversation, not only in these recorded podcasts, but also outside of this. I think he's absolutely brilliant, one of the top experts in the world in PBM science, undoubtedly. So I have the utmost respect for him, and I'm a huge fan of these conversations, and I hope that you will get a lot of value from them, just as I did. Enjoy.
So I'm going to talk to you a little bit the way that I do with my own students when I'm teaching this. And I should explain, I've got a dental training facility that I work with dentists and hygienists and therapists and what have you. And we induct them in how to do PBM practically for dental applications. But I'm not going to talk so much about dental applications. These are some of my dental friends and colleagues, right? And it's an international group, and because we all have the same problems. We're all having to either deal with people who are in pain, or deal with the after effects of people who've had pain and then they've lost some function. We seek to try and do things as gently as we possibly can, and also to try, if possible, not just to stop what's happened, which has led to the problem, but if possible, to reverse it and to regenerate tissues. And at the same time, we need to match the needs of our patients, which is something which is going to be reliable and simple and not too expensive, and something which is going to last. So it's quite a demanding set of challenges. And so what I'm seeking to do is to increase the ability of the tissues to heal and repair. And so although I'm doing some directed clinical care, which may be triggering off some issues associated with healing, I want to try and direct that healing so that the tissues are dealt with as gently as possible in order to resist, to increase their resistance to the type of trauma that can lead to more tissue damage. I want the tissues afterwards to get the best possible sort of healing and repair, and with the minimum amount of trouble after my intervention. And so if I can start to manage inflammation using PBM, this is great. So the pictures that you can see there, it's of the daughter actually of a dentist who decided to take a drink from a hot tap. And she ended up with a really bad burn on her commisure in the corner of her lips. And so her dad, who's a student and a friend of mine, contacted me saying, "Hey, Mark, what do I do? What do I do?" And this is his 10-year-old daughter. And so I gave him instructions and care, which I'll share with you later on if you wish. And we managed that on a daily basis, where he did some treatment at home, doing some PBM every day. And over a process of 6 days, you can see how rapidly the inflammation's resolved and how good the quality of the wound healing. So, how do we manage to do this? And is this something you can turn into a transferable skill? And the short answer to that is, well, absolutely, you can. You see, what we're trying to do is we have to, whenever we're thinking about using PBM, photobiomodulation, it's got to be within a bigger context, and there has to be good management of the problem. And this is where some professional input can be helpful. Because if you've got a good diagnosis, then this may be just one element of what's happening. You may have people who want to treat themselves at home after they've had some surgery, doing some PBM in order to help enhance the quality of their healing and repair. And so, although I'm talking from a clinician's perspective, I'm very happy to indicate to people some things where they might be able to add to the benefits of the care that they're receiving from their clinicians. And these are all the sort of stuff that we clinicians look for. We need someone who's essentially as healthy as they possibly can be, not like the guy in the picture. Um, we may have to do all sorts of things to help set the frame for good wound healing, and we want at the same time to design it in such a way that you're going to get the optimum response. And as part and parcel of that, as a model of care, um, there's this idea that we may be able to instruct our patients in how to use home use PBM devices as a support at home on a daily basis. And this is a new concept, something which I think is very exciting for me as a clinician, where we're working with the patients, where we're doing certain things which may be more intensive treatments or may involve some invasive stuff. In our surgeries, and the patient then at home is managing their complaint using some PBM. So what's the problem? Well, whenever you do something, say you have you twist your ankle, you get acute inflammation. Now that acute inflammation that causes you pain. There's some swelling. If you try and load it, there's reduced mobility of the joint. And that pain can last for anything up to 10 days. Typically, it peaks at about 24 hours. And so I asked myself the question, well, why? What does inflammation do? But without inflammation, you don't get healing. Inflammation is the thing which sends out the primary signal to the body's repair mechanisms, and it calls in all the repair troops. And without that, then you just don't get the attraction of all of the repair cells to the site of the injury to repair. And then after a day or so, there's some initial deposition of womb matrix, which is the basis of healing and repair. And the mop-up crew, as it were, is there on site, dealing with the site of the damage, removing damaged tissues and remodeling them. And that process then can go on for 30 days or more. And then there's a remodeling phase where the initial temporary repair is replaced with something which is more permanent. And this is very characteristic of wound healing, right? So with that model of wound healing in your mind, what we're seeking to do with PBM is we're seeing if we can reduce the peak as well as the duration of the acute inflammatory phase. And this is the point where you're getting the pain, the acute swelling. It might feel hot to the touch, and you got reduced mobility, say, of the joint, which has been damaged. And if you can reduce the peak so there's less pain and then reduce the duration of that acute inflammatory phase, this is really useful clinically, because I mean, you've had an injury, you're in pain, you want some help. So, okay, so you can do some PBM. And there's no reason why you couldn't be doing some of this at home, using some home devices of sort of thing that you can buy for home use. And then after that, in terms of the repair, you want to encourage the repair cells so that there's the maximum number of repair cells present and that the quality of the healing and repair is going to be really, really good. So if you've got a history of prior sports injuries, you may want to see if you can build a better tendon, build a stronger bone, build some more tissue there so you're less susceptible to future injury, and so that the quality and stability of the wound is really good. So this is where PBM can really score, because when you understand the dynamics of what's happening when you shine that light onto the tissues, then you've got a very potent anti-inflammatory. It can stimulate the cells so you can get more of them, and so you're going to get more matrix, and also you can sort of direct healing and repair towards the optimum within the range of possibilities for the individual, and that will depend on their health. And if you've got somebody who's elderly, who's got an impaired immune system, who's got all sorts of other pathologies, then it's very much more difficult. That's not to say PBM doesn't work. In fact, actually, the contrary, because in these groups, this is where there's a better chance that you can help to stimulate the cells to do a better job. And but whether you're healthy or unhealthy, PBM is still very helpful. But there are certain things which will hinder your ability to heal, and this is where, within the context of healing and repair, it helps if you just understand that you need to have basically a healthy body. You need to have a good diet. You need to make sure there's a good blood supply there, that the wound is stable. You're not going to damage it and let it get infected, and that there are other factors there which medically may make it more difficult for you to heal and repair. And if you understand that, then you can start to appreciate the limits of what you might be reasonably expected to be able to achieve. Because for some conditions, it's like magic. You've got someone who's healthy, who's got a sports injury, they do some PBM, and hey, they recover really fast. Whereas if you're ill, maybe you've had some cancer chemotherapy and radiotherapy, you're not so good, it's going to take longer, and it's a more arduous route, and you can't expect to see instant results, but it will still be of benefit. PBM, as you know, affects all the different cell types. It affects every single type of living cell. So whether you want to grow new nervous tissue, whether you're looking at stimulating the white blood cells, which are associated with your immune system and your ability to combat infection, whether you just wanted to generate more bone, whatever it is. I mean, these are all things where PBM applied appropriately, you can get all of this. And so this is all really good stuff, especially with people who've got an impaired ability to heal and to repair, who are medically compromised. Say they've got diabetes, or they're obese, or they're on a whole bunch of drugs which can impair healing. And lots of prescription medications have got this effect of impairing healing. So this will help just promote the ability of the cells to operate to their best capacity within the ability of that individual to heal and to repair. So the clinical applications of this are huge. I mean, as you know, it's everything from central nervous system conditions through to the management of cardiovascular disease, respiratory infections, arthritis, sports injuries, as a support for people who are having various forms of surgeries. I mean, dentistry. It goes on. Anything which has got an itis in it, which is related to inflammation. This is an anti-inflammatory. And so all of these medical conditions, I mean, Inflammation is the name of the game in medicine. Most stuff that's happening, which is causing people ill effects, whether it's Alzheimer's, whether it's traumatic brain injuries, or whatever, most of it is related to inflammation. And if you've got a tool which you can use to manage that inflammation, that without damaging the ability to heal and repair, that's fantastic because you actually need inflammation. If you haven't got inflammation, you don't get that signal that calls in all the repair troops to the site. And this is where people who are on steroids that systemically reduce the whole body's ability to have this inflammatory response, they suffer. They just don't heal so good, you know. So I think the selective application to the area is working on exactly the same targets as powerful drugs like steroids. You know, it's
Yeah,
actually,
Dr. Cronshaw, if I can interject one point, that
yeah.
this topic, I feel there's a lot of confusion around this topic of inflammation and its role in disease, its role in aging and longevity. There's even researchers who have promoted the concept of inflammaging, that sort of chronic low-level inflammation is a major driver of biological aging itself and therefore longevity. And it's been, as you mentioned, implicated in many different disease processes. But to some extent, it's sort of like it's to a large degree, it's like if you've got a house on fire
Mhm.
and or a neighborhood on fire, and the fire department shows up, and you've got firemen in there, with battle axes chopping down doors and with fire hoses spraying stuff and using fire extinguishers. And then you go in and you measure that, from the outside, and you say, well, these firemen and these fire trucks really seem to be associated with these disease processes.
Mhm.
But the firemen are and the fire trucks are not what's causing that situation in the first place. And so there's a lot of
Mhm.
misattributed cause to inflammatory cytokines, to inflammation itself as being the cause of these events.
Mhm.
And yes, it's circular. Yeah, there's a case to be made for that kind of thing.
Mhm.
But I think that this very idea of the inflammation itself being the cause can be debunked very easily, sort of in a science 101 sort of way. Let's say you take
Mhm.
non-steroidal anti-inflammatory drugs, which lower inflammation. Well, they don't actually positively affect most disease processes. Yeah, they can temporarily alleviate symptoms like pain, but
Mhm.
they don't actually positively affect any of the disease processes that are supposedly caused by inflammation. Or and they also don't translate into increased longevity. So we know that taking drugs to block inflammation doesn't actually translate into lower rates of disease or improved longevity,
Mhm.
which I think gets at this idea that the attributing cause to the inflammation itself is probably guided. And I think that there's an important distinction here, which I think you are kind of alluding to,
Mhm.
between something that is combating inflammation by simply blocking it or suppressing it, like a drug might do, versus something that might reduce inflammation by actually promoting better cellular health and
Mhm.
healing processes.
Yeah.
Would you agree, or how would
Well,
you sort of comment on what I just presented there?
there's a lot that I would agree with. I mean, the issue really is to do not with eliminating inflammation, because if you eliminate inflammation, that's the body's response to injury and trauma and insult. I mean, inflammation is crucial to health, and people who uh, can't trigger that inflammatory response for one reason or another, they're severely mentally compromised and they're much more at risk for all sorts of problems, including infection. That so the objective really is to manage inflammation to improve the experience of the patient. And at the same time, the issue is how to deal with chronic inflammation because there's a
Mhm.
difference between an acute and a chronic inflammatory condition. I mean, when inflammation goes chronic, this is where it's kind of failed wound healing. And this is where there's a persistent problem which the body just can't deal with. And so all that happens is that progressively you get tissues that get removed and there can be progressive loss of damage. And so in dentistry, this is where people who've got gum and bone disease gradually lose all the attachment and all the bone around their teeth, and then they end up with no teeth, And but it can happen in a joint where all the cartilage disappears, and then you lose the bone, and then you're in trouble. So I think this concept of managing inflammation is essential. It's certainly true to say that the manifestations, the things that cause people to go and see their doctor or to seek help, whether it's self-help or within a medical context, a lot of it revolves around the issues that they experience because of inflammation. They're experiencing pain, they've got swelling, they've got some persistent issues which are just failing to resolve. And so my point really is that PBM is a tool. It's what I would call an adjunct, which is something which you can bolt on to other stuff that you can do to try and help both relieve the symptoms as well as stimulate a healthy pathway towards healing and repair.
Right. I mean, I think a simple example of this, like I know that there's some research in athletes who, let's say soccer players who get ankle sprains, and
Mhm.
it's been shown that applying photobiomodulation improved the rate of healing by about 100 or 200%, meaning they got back on the field, let's say in 2 weeks instead of 4 weeks, like the control group that didn't use photobiomodulation, which, again, I think gets at this distinction of this isn't just something that is alleviating symptoms associated with inflammation, it's actually speeding up cellular regeneration. And
Yeah,
as a byproduct of enhancing the actual regeneration at the cellular level, the inflammatory processes are sort of that process is sped up or is optimized in a way where it's made much more efficient and effective, and the time of its presence is shortened rather than simply taking a drug that suppresses inflammation and reduces pain.
exactly. And also there's one other exciting thing you could add, which is the timing of the intervention, because the sooner you do it following the injury, the less acute inflammation you get, because you never totally
Mm.
eliminate inflammation with PBM, and which then can help reduce the amount of tissue trauma. And also, if you preventatively treat someone, so if you condition them before the event, then again you can reduce both the severity as well as the frequency of them having an injury. So the timing of PBM interventions is something which is very exciting, and as I'll discuss later, this has got some very important implications for patients who are undergoing cancer therapies of one form or another, where they can suffer the ill effects of radiotherapy and chemotherapy. And so the timing of the intervention can be a critical factor. So let's carry on a little while longer. But no, I welcome your quite astute comments. Say you're right. You need information, but you can have too much of a good thing. That's the message.
Mhm.
So when I got involved in the clinical research in this, I wanted to know, well, how does it work? How much of it do you give? How do you go about doing it? Is it a specific device I need? Is it a magic wavelength? Can it be a laser? And can it be an LED? How often do you do it? And what's the sort of things that are going to screw me up, and make it difficult for me? And what are the complications and things I need to know about? And so, right at the outset of when I started my doctoral research, I wrote a review with colleagues Stephen Parker and Praveen Irani, where I was trying to get a handle on dosimetry, as well as trying to understand how it is that you can achieve pain relief, which is analgesia, using this very useful effect. And so when I delved into the literature, I found that there were in the literature, in the peer-reviewed scientific reviews and meta-analysis and what have you, that there were two dose windows. That there was a lower dosimetry, which was associated with the increase in activity of the cells and enhanced production of biomatrix and better healing and good quality immune response. And then at a higher window, you didn't see that increased activity. You saw inhibition, but also this was associated with pain relief. You could use a higher intensity of energy, and this would be very useful in relieving pain. So I thought, okay, great. So I've got some initial ideas of what the previous research had done, but I still don't understand how best to do it. So the lady in the picture, she's got a cold sore. She's got a herpetic lesion on the lip. There, I'm actually using a laser rather than LED, but you could use an LED for this. And what I'm trying to do there is to arrest the progress of that herpetic lesion and to help stimulate the immune response, and also to see if I can turn it around so that there'll be very rapid wound resolution, which you can do when you can start to understand how you can selectively apply the parameters. So let's build on this. So I was thinking, well, okay, what are you trying to achieve? Here I'm thinking with a clinician's brain, which you could do this at home. What am I seeking to do? Am I looking to prevent a problem, or am I trying to manage a problem? And is the management issue one of relieving pain and inflammation, or do I just want, after I've had some surgery, just so I get really good healing, and or maybe a combination of them all, the images in the picture show a patient of mine who had a really bad traumatic ulcer in their lip. They bit themselves really badly and it got very inflamed. It's very painful. And so I applied some PBM, and it took me 2 minutes, and you can see there's already some signs of reduction in the inflammation. There's a reduction in the edema, which is the swelling associated with the wound. The wound itself is already beginning to contract slightly, and all of that's happened inside of 2 to 3 minutes. So this is a very powerful thing, and that's something which both relieves the patient's pain, and at the same time it's stimulating the heat and promoting resolution of a wound which otherwise was just going to persist for a while, and which was a nuisance to the patient, which is why they're there to see me. So lots of my patients, unfortunately, aren't well. They've got all this stuff going wrong. They've got multiple pathologies. I mean, virtually all of my patients over the age of 50 are on 3 or 4 different prescription medicines of one form or another. And so within the ability to heal, you can't just look just at the condition, the specific problem that you might have. It's good within a bigger context, because quite often you might have people who've got maybe heart disease, but they may also be depressed as well. And there can be other illnesses there too. They may have some diabetes. And so there can be this sort of complication of these different pathologies, all of which then, as a patient, add up to a lot of it separate problems. So when you start to think about doing PBM, you may be thinking not just of treating the immediate condition, which might be the ulcer that's not healing, or your bed sore, or your carpal tunnel syndrome, what have you. It might be within the greater context of seeing if you can help systemically as well. And this is where PBM can score, because you can use it either locally, and also you can start to think about treating the whole person. And it's a concept that I describe as bioenergetics, where we're starting to have an effect on the systemic health of the patient, as well as a local effect on the targeted tissues. So hang on to that thought for a minute, Harry. So when you start to think about doing this, you need to know a little bit about where is the problem? Is it on the surface or is it deeper? And so the lady in the picture has got a muscle-related problem, which has got some pain, which is causing her headaches. And it's a muscle that's gone into spasm. So I'm using a device there, which is actually a laser, to get that muscle to relax and to improve the blood flow there. But to treat this, I've got to know, where is it? So ask yourself the question, is this on the surface or is it beneath the surface? It's a very simple question. If it's a skin condition, then it's a very different thing than if it's a subsurface target. and that will then affect your dosimetry as well as perhaps the type of device you use and the wavelengths that you use. And it's got some implications for the technique. So it's a fundamental question. Ask yourself, what am I trying to achieve? Is it pain relief, inflammation management, or healing, as well as what is it that is the outcome I'm seeking? So when you start to come down to the how do I do it, there's some basics you have to understand. And I know listeners to this podcast will probably know this, but just to reiterate it, so we're talking the same language. There's the unit of currency when we're talking about dosimetry is a joule, which is a unit of energy, and the metric for photobiomodulation as a therapy is the number of joules we're administering to an area, which by convention is the joules per square centimeter. Some people call this the dose, some people refer to it as fluence, some people call it radiant exposure, which is its proper technical term. Now, the rate at which you deliver it is the power. And so there's a very important concept of irradiance, which is the concentration of the power in the unit area. And a joule in 1 second is a watt, and a watt is the unit of power. Now, don't worry, because we're going to reiterate this and we'll explore this a little bit more clearly, just so it's a little bit more obvious as we're going along. And then you can think about, well, what tool am I going to use? Am I going to use a big flatbed LED? Am I going to use a small torch device? Am I going to be using an LED? Am I going to be using a laser? And so there's a whole string of questions then you have to answer as to what is it that I need to use to best treat this condition. And then you then think okay, well, I've got a range of tools available to me. Maybe I'll use a small applicator just for a little ulcer on my lip, or alternatively, maybe I'll need to use a big flat LED to start to deal with large areas associated with other conditions. So with issues which are related to parametry, this is where it starts to get head spinningly complicated, right? And because I mean, there's all these different elements to it, and this is where it can be really quite daunting because there's issues to do with do you keep it static or do you move? How big an area do you expose at the surface of the tissue? Are you going to hold it in contact with the skin or at a distance from it? Are you going to press it into the skin? And then the beam itself, the light, it can diverge. And if you're further away, then it's a bigger spot than if you're closer up. And then you can do things with the beam, so you can turn it on and off, which is what we refer to as the emission mode, and you can gate it, and so that you can have peaks and troughs and times when it's not on. And then there's the amount of energy you're delivering and all the rest of it. And then there's all these other parameters, and you're thinking, oh my goodness, this is so awkward. But actually, in essence, you can reduce this quite a lot to some fundamentals when you start to think about what is it that I'm actually doing. So although there are all these parametry, and when you go into the literature, there's a huge amount of confusion in the scientific literature. So how normal people are supposed to expect this, goodness knows, it's head spinningly complex because each of these things can be interrelated and it can affect the outcome. And if you're not careful in the scientific study, you can put too much importance to the magic formula which gave you the result that you're seeking, and you can claim, Eureka, this is the way to do it. Whereas actually, it's just because of the way in which you packaged the energy in the form of delivery. So there are many, many problems in the literature because of that. And so, in an effort to try and remove the fog and let you see more closely, rather than focusing on all these complex parameters, let's just move a little bit further forward in this conversation, just so we get a better handle on what we're doing and what we're trying to achieve. So there's a general a concept of what happens to the light when it enters the tissues, and a number of things can happen, and it can just be spread, which would be called scatter. And you can see those images of somebody's lip where the red light that's being applied is just spreading throughout the tissue. I mean, you can take a red LED and put it into your mouth, and it looks like your whole face is lit up. That's scatter, and that can be associated with what we refer to as attenuation. And this is where the energy is falling off quite rapidly because the energy has been diffused into quite a large area. And And so when you start to apply it to something like skin, it rapidly falls off. I mean, these are some figures from a colleague who suggests that at a centimeter deep, you're down to a third. In fact, I could show you other studies, depending on wavelength and other one of those parameters I was talking about, you can have between 2 to 10% of the energy at depth, depending on the source. And there are all these depending on aspects of it. So scatter is something which is a feature, particularly with red visible to near infrared wavelengths, because these wavelengths are quite poorly absorbed. So as opposed to the energy being absorbed by the molecule, most of it is scattered in these wavelengths. So you get a big optic footprint. So when you shine that light, even if you can't see it because it's near infrared, the whole area can be illuminated like a light bulb if it's just outside of our capacity to see. Now, some sources are concentrated so that the energy is in the middle of the beam, and this is particularly important when you're dealing with lasers. So the video picture you can see there, it's a chiropractor who's probably not a million miles away from where you are, Ari. He's in California, and he's doing some PBM using a high intensity laser there. And the different colors indicate the temperature of the tissues. And you can see that in the middle of the beam, there's a lot more heat. It's hotter in the middle of the beam than on the periphery. And this is what we refer to as a Gaussian effect. So the Gaussian effects is something which is very important in laser therapies. Now, members of the public generally are not able to access lasers apart from very weak laser pointers and things which aren't really going to be therapeutic. But even an LED, there's going to be some Gaussian effect. But as opposed to it being a strong effect, this is less of an issue for LEDs. But anyway, let's say that with a laser, you're going to have maybe 68% of the energy in the middle of the beam. And that's something which I'm mentioning now because this is impacts on some of the research findings, which no doubt we'll be discussing later on in regards to temperature and heat and the significance of those in regards to PBM. So the Gaussian effect is something which is
Uh, do- Sorry, actually, I'll let you complete your thought. I want before you move on from this slide, I want to ask you something about it.
yeah, sure. So when you're thinking about delivering the dose, you might think, okay, I've got this set up at 1 watt per square centimeter, okay, which would be a dose I wouldn't use for PBM, but just for convenience, just for numbers. And I've got a device there where the in the middle third of the beam, 70% of that 1 watt is being concentrated. Now, because it's a big beam, I got to stick, a lot more power into it to provide that 1 watt per square centimeter because the example you can see there, it's got 7 square centimeters, so it's quite a large beam. And so with if I was wanting to have it as an average of 1 watt per square centimeter, I'd have to have the power output up to 7 watts, which is a lot of juice, isn't it? But then thinking, okay, well, I'm just going to go for 1 watt per square centimeter. You turn it up to 7 watts, and then 70% of that 7 watts is in the middle of the beam. And so that basically means that about 6.5 watts is being delivered to that central area. That's a lot of juice to a small area. And then you're going to start to get some photothermal effects. And as in the middle of the beam, particularly if it's a really big area, it carries on peaking because a Gaussian beam, it comes to a point, but like a traffic cone. Then in the central area of that middle third, again, it's another 70%. And this is where you can seriously start to overheat things, which is why with high intensity laser therapy devices, it's really important with big beams to move, because if you don't, you're going to cook things in the middle of the beam. And that mistake has been made in some very important scientific studies, which have led to some conclusions being reached, with which I profoundly disagree. And so the
In
Gauss
other words, you're hinting at that certain studies have found a negative result, let's say overt tissue harm, or at the very least that a particular treatment using a laser was ineffective, failed to show benefits, and you think the big confounding variable is how they used the device itself, and therefore they overheated the tissues.
Absolutely. And they've come to a false conclusion because they've assumed that this is a phototoxic response, whereas really it's a
Right.
photothermal rather than a phototoxic effect. And basically all they've done is just overheated the tissues, and that's a methodological problem. And I mean, this is from a paper I published under 2 years ago. So when you're looking retrospectively, you're looking at previously published papers going back 10 years ago, when people were less alert to this, then it's entirely understandable why people might have jumped for the wrong conclusion, and it's the nature of science. It's not bad science, it's just that you get somebody awkward like me who comes along and says, we thought about this, and it changes their conclusions. But the conclusions that they've derived from that are having some important impact on dosimetry, particularly in regards to pain relief, and so on a mission to try and get this message out. So the Gaussian beam is something which, particularly with lasers, is really important. With an LED, because with an LED, unless you've got some special optics screwed onto the LED, then generally the size and divergence of the beam is huge, as opposed to it being quite a relatively small area. And so, as opposed to it going to a really high peak, it's almost like a sort of little plateau, like a little speed bump, really, as opposed to it being a big mountain, And so then it's less of a biohazard to intense dissymmetry in the center of the beam, depending, of course, on the output power of the LED, But generally, the LEDs, you're looking at what, 25 to 50 milliwatt output devices, and so you're not really going to start putting high wattage into in order to fill large beams. And so, having slaved that a little bit, ask a question, Harry, because I'm all agog. What were you going to ask me?
Well, I want to point out something obvious here, which is that as you're showing in this image, the tissue where you're applying this laser is heating up. It looks like based on the graph, it's somewhere, I would guess, 41, 42, 43
Mhm,
degrees Celsius, somewhere in there. Now, in certain literature that you see in the field of photobiomodulation,
mhm,
and in, for example, my podcast with Dr. Praveen Irani, he makes the argument that and I know you know where I'm going with this, and I know that this is a topic we could spend a lot of time on. We've already touched on a bit, but I just want to bring it to people's attention in the context of what you're presenting here. Um, certain people have made the argument that photobiomodulation is sort of by definition, the way we define photobiomodulation is that it is non-thermal.
mhm,
I believe Dr. Arani's exact words in the podcast that I did with him were, I think that there is no place for tissue heating in photobiomodulation.
mhm,
So presumably he would, and I don't want to, I mean, this sense to me. I certainly don't want to misrepresent his position, but based on those statements, it would seem that this would not classify, based on this definition, as photobiomodulation,
mhm,
and that it would be put in the category of, let's say, photothermal effects.
mhm, mhm,
And therefore,
mhm,
based the effect is purely based on tissue rather than PBM effects. And I mean, once you start going down that train of thought, then you start to wonder, well, would there, if this is only about tissue heating, you're only getting about
mhm,
versus, let's say, a hot pack,
mhm,
just this whole, like, bag of sand that you might throw in a microwave and slap a hot pack on an area, right? There's a number of layers to this sort of story, but and I think a big part of this is semantic, is just how we define what photobiomodulation is or isn't, based on how we are saying it's these sets of mechanisms, but not these other sets of mechanisms.
mhm.
Photomodulation is only below X temperature and so on. But how would you describe that picture?
Well, I mean, to say that there is zero heat associated with any photochemical process or photon transduction, as we refer to the energy transfer between the light, the photon, and the living portion of the cell, as being without any heat, is just impossible. Inevitably, particularly with red to near infrared wavelengths, you are going to get some heat. It might be a microscale event where you're looking at things where you need special probes to scientifically see the rise in temperature inside the cell at the point where the energy is being absorbed, as opposed to overtly heating up the whole cell or the whole tissue. And so I would support the idea that you got to be really careful not to overheat tissues. I'm completely empathetic to that. That's part and parcel of any kind of energy transfer process. You are always going to have some heat. And I don't think Dr. Arani would argue with that because I think the distinguishing feature is that PBM, photobiomodulation, is not heat. You could be associated with heat, but it's not the same effects. PBM has a whole variety of other effects. It's got a selective effect on specific areas of the cell. And although, again, you may get some localized heating, for instance, with some of the ion gates around the membrane, the TRPVs, you can get some localized heating, which will then stimulate those ion gates to open. You're thinking, well, is that a PBM effect or is that a heating effect? And this is where you're starting to split hairs. You're starting to argue really about how many angels are going to sit in a pin. Because I mean, uh, the issue really is it's energy transfer, and you're going to get multiple overlaying effects. And so to be too purist on this and say that there is absolutely no place for a photothermal response in PBM, well, good luck with that, because I mean, I don't believe it. To give you an example, I do surgery using surgical lasers, and the healing is fantastic. It's got what got me interested in PBM, because outside of the zone of surgical destruction, the energy is low enough to start to have a 2-for-1 PBM benefit, where I'm conditioning the wound bed at the same time that I'm doing my very selective surgery. And the surgery will involve some photothermal events which may disrupt tissues and break it up and heat them up above 100 degrees centigrade or higher. Yet beneath that, you get fantastic healing. And trying to separate out photothermal effects totally from PBM, I think you're throwing the baby out with the bathwater. I would emphasize that PBM is not the same as heating. It's a different effect, but the two effects themselves, especially when you start to think about three-dimensional models, we're big creatures, people, and if you start to have high intensity, as you can see in the image there of the lady who's having some laser therapy to presumably help her with some fasciculation on a muscle. At the surface, that will be potentially producing some minor disruption in the tissues, which might trigger some remodeling. And that's almost like diathermy, and as opposed to PBM. Whereas in the depths of the tissues, because the energy will have fallen off quite sharply because of this effect of scatter and attenuation, then you can be having some PBM effects, and you're getting a 2-for-1 benefit. And when we're talking about surgery, we say, well, it may look ugly, but the healing is beautiful. And so for the sort of things that people are using at home, we certainly wouldn't encourage them to start overheating things. This is not what you want. You want to be gentle, and the devices that are generally available for the public to use intentionally are very safe. You really would have to go out of your way to cause yourself some photothermal damage, and so the safety factor is one of the reasons why they're available to people who are relatively untrained. Whereas when it comes to high intensity laser devices, there is the need for special training and awareness and all sorts of safety precautions. And the sort of devices that we're using now, they've got built-in photothermal cameras, and there's all manner of things which are by design let us more safely apply really high energy, but without causing the sort of damage that causes Dr. Arani to lose sleep. So hopefully we've answered that one. We can talk more about this as we go on because it's a great
Yeah,
conversation.
and I know we previously discussed this in some of the irradiance parameters that are 500 milliwatts per square centimeter in the near infrared range, and about 300 in the red wavelengths. And I
Mhm.
know that also there's more complexity to that as far as the method of application, laser versus LED, and spot size and things like that. But sort of more broadly, those were the parameters we discussed and are also discussed in, was it the paper by your student Zane and
Yeah,
Dr. Hamblin?
Yeah,
I
yeah.
think I think that's the one where they review
Mhm.
the photobiomodulation parameters that are involved in overheating the tissues.
Absolutely. And so when you're thinking about applying the energy, you might think, okay, I'm going to use a fixed irradiance. I'm going to go for, just for example, you might think, I'll use maybe 500 milliwatts, all right, which is, top end for maybe an 8-10 nanometer near infrared source based on the Zane paper. And but then the spot size is quite small, and so you may be using a surface light application around about a centimeter. So you set the device to half a watt, which will deliver 500 milliwatts per square centimeter, because it's half a joule per second. And then you can start to think, okay, I'm applying that to the surface. I want to deliver 5 joules to depth, and then you can kind of calculate how many seconds it will take you, right? You think, oh, great. And then if you use a bigger applicator, then you might then start to think, well, I really do want to deliver 5 joules, but I want to deliver it so it's not going to take me quite so long to a bigger volume. So you use a larger applicator, and then you're starting to step up the amount of power that you're applying by a factor of 10. So then you're being to more realistically deliver your 5 joules per square centimeter at a centimeter depth. But then if you use a really big spot size, because of this Gaussian effect, particularly if it's a laser, then because the energy in the mid third of the beam is so much higher, then you need to be careful with your dosimetry, because otherwise you can be doing a bit more down there than you realize. You can start to over energize the tissues, and you'll be delivering more energy to depth. So this is my explanation why it is that big spot size devices, particularly if it's a single source like a laser, can start to really deliver a lot of energy to depth. Whereas with LEDs, these things can still be therapeutically beneficial. We'll have this conversation later on in this presentation, if you wish, where we're looking at the pros and cons of LEDs and lasers. But then, as opposed to it being one big LED, you've got multiple LEDs, and the effects in terms of the tissue saturation of the photons and the distribution of the energy is quite different. So I think when you're thinking about dose delivery, you've got to think about spot size. When you're thinking about irradiance, then that is something where the amount of power that you're delivering, if it's going to have this Gaussian effect, you've got to take into account with big beams the fact that in the middle of the beam is going to be an awful lot more energy. And whereas
With
for smaller spots, cumulatively, and you can, do this, but without so much of a risk of over energizing tissues in the middle of the beam.
you can get from LEDs, because the energy is it's spreading out. You can get some overlap of these areas,
Mhm.
as I understand it, interference essentially of the light uh, before the light reaches the skin and after beneath the skin. And
Mhm.
so having, as opposed to just one single source of that light, having multiple sources adjacent to each other
Mhm.
creates, I don't know if you'd sort of say it's a different effect, but it seems basically the light, it enhances the penetration light depth.
Well, I mean, I've got a great slide on this later on, so we'll come
Okay.
back to that one. Hang on to that thought, Ari. We'll return to it, okay? Because I got a nice slide
Okay.
which discusses this.
Can can I mention one more thing while we're
Yes,
on
of
this
course.
slide here?
Yes.
I think this three-dimensional picture here is really important to understand, because sometimes we see, particularly when the biphasic dose response is discussed. I know that's something we're gonna touch much more upon in the multiphasic dose response.
Yeah.
But you see these numbers thrown out in many of these biphasic dose responses, like 1 to 5 joules per square centimeter
Mhm.
is the stimulatory range, and then above 10 joules per square centimeter is the inhibitory range.
Mhm.
But this is the dose that is it's basically the dose that's delivered to the tissue where
Mhm.
that would be the case. And so sometimes people get confused as to the surface dose
Mhm.
versus the dose that is being delivered to depth. Let's say you're trying to treat a knee joint, for example, and you're trying to deliver light to, let's say, a centimeter, 2 centimeters of depth, three
Mhm.
centimeters of depth, as you outlined in this image here. the percentage of light that's from of the surface dose that's reaching those different depths.
Mhm.
In order to deliver, let's say, 5 joules
Mhm.
per square centimeter to 2 or 3 centimeters of depth, you
Mhm.
need a hell of a lot more at the surface to be able to reach that. Is that correct? And how would
That
you speak to this
Well, I
distinction?
mean, this is all great because I mean you're following very much the logical processes that I went through when I was studying this for my thesis. Because I thought, okay, so we got this target. We've got to get these photons down to 3 centimeters. This means we're really going to have to deliver a lot of energy at the surface, but then you're going to end up overheating the surface tissues. And what's going to happen? So I did a paper which is all about photothermal aspects of photobiomodulation therapies, where I did some thermography under different conditions using lasers, trying to divine ways in which you could compensate for this. And one of the ways is by optical scanning, and so then you're spreading it over a larger area and cumulatively starting to feed the photons into the target. Another concept is that with lasers, the beam is quite a tight one. And so in the core of the area, then this is like a probe which is reaching into the tissue, and you can kind of move it around. And so you're delivering photons over a period of time, but you're not sort of overheating the whole volume of the tissue because the scatter is less lateral. It's more coming down to a point. It's an optical effect. It's when the light enters the target, it's entering a tissue which has got a higher refractive index. So then the light is bent towards the normal. The normal is the vertical. So you come in like this and it bends the light like this. And so you get forward transmission of the energy, which is one of the reasons why lasers, which are a coherent beam where all the photons are in the same phase and time, have got a better capacity for reaching deeper into the tissues than an LED. And so there's all sorts of finesse to this. But let's carry the conversation on because we're in danger of getting
Sure.
in too deep. With an LED, the beam is divergent. And what that means is if you look at that image there, that's actually a laser I'm using. When you're far away, it's a big spot. And when you're close up, it's a very tight spot. Now, the what we call the beam divergence angle, which is the size of the spot with an LED, can be huge, much bigger than with a laser. And so as soon as you're any kind of distance away, then the size of the area you're treating is very much greater, and that has a big impact on dosimetry. Because if you're trying to apply a dose at the surface, as opposed to one which is an inch or two away, then the intensity of the source really falls off very sharply. And so when you're 2 centimeters away, which is roughly just under an inch, then there's about 4 times the area. And whereas with a laser, it's a smaller beam divergence angle. So all these LEDs, unless they've got a special lens screwed onto them, and you can get LEDs that have got that, and you don't tend to see them very often in PBM devices, then distance is a critical parameter. So I did a paper looking at torch type LED papers that came out recently, and I looked at the instructions, and people were saying, well, hold them 1 to 2 inches away, and this is just not good, because the that completely screws up any hope of getting the dose right. Because the further away you are, then you'll markedly reduce the surface dose, and that will then have a big effect on how effective you're going to be, unless it's a very superficial condition. So moving on. So which wavelength is it? Now, this is a hot topic. I think everybody's got their favorite wavelength, and I really like a 1064, no, I like using a red wavelength, no, you want to use an 810, so I did some measurements using a thing called a beam profilometer, which is like a camera, and it just measures the amount of power that emerges when you shine it through tissues. And those pictures on the left, on the top, that's a 1064 nanometer, and I've got 10 watts of power going through that. So that's a lot of power, and it's barely getting through into the tissues, into a 3 millimeter thickness of tissue. Whereas with shorter wavelengths, you can see there's an appreciable volume of tissue which is getting exposed to it. So this concept of this optic window, which you can see in the middle slide there, where from about 600 through to about 1,000, it's like a funnel like this. And the wavelength which has got the least scatter and the least absorption is around about 800 to 810 nanometers. So if you want to go deep, that's a good wavelength. But any of those wavelengths will do it. It's just it might take you longer to deliver photons to depth using a shorter or a longer wavelength than it would be if you used an 800 to 810. And so there are other aspects related to your choice of wavelength because the amount of energy associated with the photon, which is the unit of light, um, is dependent on the color. And so really short wavelengths like blue wavelengths and or ultraviolet wavelengths, there's a lot of power there. It's a short wavelength, and so all the power is condensed into a very short cycle. And this is where you can start to generate a lot of heat. There's also a lot of energy there available for photochemical events, such as converting dehydrocholesterol into provitamin D in your skin with UVB. Whereas with the longer wavelengths, there may not be enough energy there to produce these photochemical effects, but you can start to have other effects, which you can include photothermal effects, photoacoustic effects, photomagnetic effects, photofluorescent effects, and cumulatively, you can then start to build up sufficient energy there to start to generate enough energy to drive forward the chemical change that you're seeking. So the choice of wavelength in part is to do with, well, what is it you want to do with it? If you want to heat something up, then great, use a blue wavelength or an ultraviolet one. So if you want to kill some pathogens, some Staph aureus or a herpetic lesion or something like that, so then a blue wavelength is very hot and very quickly you'll be able to deactivate that virus. Whereas if you're seeking to enter the tissues and penetrate deeply, but without heating things up, then something which has got really quite poor absorption and not so much scatter, like the 800 to 810 nanometer, this is a good choice. In an effort to make it easier to get the dosimetry right, then Praveen has done some work where he's come up with this calibration scale, which he calls the Einstein dose, which you can love or leave. I mean, the difference it makes in the red to near infrared is around about 10% either side, so it's not a mega difference. If you're doing things which are high intensity laser therapies, then it makes a big difference because you might be doing that for quite a long time. And that extra 10% or minus 10%, that can then be a significant factor in dosimetry. So I'm not saying that Praveen's wrong to come up with this concept. It's just that for LED treatments, I don't think you need to get too hung up about Einstein dose, and this isn't something which is really going to be terribly germane to the sort of stuff that you can achieve with an LED. So,
Dr. Cronshaw, one second before you go on, I want to point out one thing here on depth. You see a lot of these on the previous slide. You see a lot of these types of images online. Quick Google search will bring up many similar images of showing wavelengths, different wavelengths, and how deeply they penetrate. What's important to note here is the scale, and you're seeing wavelengths penetrate no more than a few millimeters. They're showing in the 600s, the 600 to 700 nanometer range, which is red wavelengths. They're showing roughly 2 millimeters of penetration depth. I mean, you're not even making it to the hypodermis. You're not making this basically to most people would be interpreted as, oh, this light doesn't even make it through the skin. And the same is true even in the 800 and the near infrared, where we talk about, what, for example, you just gave the example of if you want to deliver light to tissues, would you use let's say 810 nanometers. But based on this image, it's only showing, let's say, 3 to 4 millimeters of depth of penetration, still not even making it all the way through the layers of the skin. And this is something we touched on previously, but it's this. I think there's enormous amount of confusion around this whole topic of penetration depth of light because of images like this that suggest this light is not even making it through the skin, and yet you can do that simple at-home experiment that kids do in a closet with a flashlight shining light through your hand. You can see, yep, there you go. You can see light clearly penetrating all the way through the skin on one side, through the entire hand,
Yeah,
and out the skin on the other side.
absolutely.
And we have studies showing 50 millimeters, 75, 90, or even in some cases up to 100
Mhm.
millilitration, even use which don't penetrate as deeply as let's say the 800s, something like 810, 830.
Mhm.
I mean, I just find this really kind of bizarre that you see so many images that imply only 2 or 5 millimeters of penetration depth when the reality is so different.
Well, I mean, the issue is partly the sensitivity of the human eye when it comes to viewing visible wavelengths. I mean, Praveen says that the retina can detect something as low as one single photon, which I found is extraordinary. And so the exceptional sensitivity of the human eye is such that you can detect really low levels of energy. So when you're looking at something like this, you may think, oh, that's it. There is no light getting beyond about 2.5, 3 millimeters with these red wavelengths. But that's a threshold which is around about 37%, because by convention, below that level, it's regarded as being the convention depth for penetration. Whereas the
Referencing the 1 over E discussion we had
that's right.
previously.
So this is where that energy carries on, and because you can detect photons visually in the visible spectrum, like that red image, down to the microwatt range, which is like a millionth of a watt. It's 10⁻⁶ watts. Um, it can appear that the whole thing is just illuminated like a light bulb, and the amount of energy you're actually delivering at a distance is very small, but you can still see it. So the photons just keep going, and so there will be tiny amounts of energy way beyond anything that this image is showing. And this is where, when you have high intensity devices like high output devices at the surface, that 37% becomes really significant. And because that 37% might be well into the therapeutic range and beyond for tissues far beyond that cutoff point, from which, by convention, you've reached the limit of how deep that particular light wavelength can go. So let's keep going, because we got a journey ahead of us. So I've tried to summed it up. This, I mean, this is something I look at and I understand it, but hey, I'm sorry it's complicated. But it's basically, you've got all the different colors on the left, from the shorter wavelengths, which are high energy, through to the longer wavelengths, which are lower energy. And then I'm looking at the dose, which is the x-axis, where you're stepping up the dose. And then I've got the different effects I'm trying to achieve, where you're looking at stimulation as opposed to inhibition. Because I would argue that, as opposed to it being an all or none response, you've got a stimulatory zone, you've got an inhibitory zone associated with analgesia, and then you're into the area where there's a hazard. You can start to get tissue damage. And the point of this shows that the shorter the wavelength, the smaller the dose before you start to get over to adverse effects. So if you use something which has got a very short wavelength, ultraviolet light, then it doesn't take long and you start to damage tissues. Whereas if you're using a much longer wavelength, it can be a much higher dose and you'll still be in the stimulatory zone, and it has to be an even higher dose again before you get an inhibitory zone. So this is where you can start to understand the merits and the disadvantages and advantages of different wavelengths. I think it's less to do with specific photon being the magic bullet that pushes the switch. It's more to do with the transfer of energy that associated with that photon to the cellular target, which can then produce a variety of effects depending on the accumulated energy of the photon. So that's quite a complex statement, and we'll revise that when we go back into this. But the point is really that each of these different colors can have different effects, but in part it relates to the dosimetry that you apply. So people say, oh, don't use blue wavelengths. That's going to be damaging to your skin. It'll age your skin, but it depends on the dose. and a very low dose is actually stimulatory, So there is this kind of inverse response where the shorter the wavelength, the more intense the source. And then if you start to think about this sort of graphic here, where you're trying to work out whether you're trying to be in the low end stimulatory zone or the inhibitory zone, certainly you want to avoid the damage zone. The shorter the wavelength, then the more the hazard, and the smaller the dose that you need to administer. It's not an absolute that some of these wavelengths, unless they're very short wavelengths, like ultraviolet, will inevitably lead to tissue damage.
Are you trying to make the case for use of screens and computers, blue light emission from them as being anti-aging for the skin?
No, absolutely not. No way. No, 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 no. And in fact, they can be things which can start to really screw up your circadian cycle. And also cumulatively, there is even concern that they may progressively contribute towards some retinal issues. And
Right.
there's an area of continued research. At the moment, there's no consensus on this, but there is concern that some of these blue wavelengths may represent a biohazard. And no, I'm certainly not gung ho about using blue wavelengths near my eyes. I think if you're using blue wavelengths, even if it's a blue wavelength LED, I suggest that you put some sunglasses on. Just protect your eyes. Because I mean, there are examples in literature of children who've used blue LED laser pointers and things and permanently damaged their retina. And
Yeah.
that's with a low
It,
output
there are some LED based PBM products that are now putting blue light
Yeah.
in some of these devices.
Oh, absolutely, and that can be something which you could actually maybe benefit from if you've got an understanding of what it is that the blue light is actually doing, and because each of these wavelengths has got certain attributes which can help you. And I mean, blue light is something which is the best wavelength of all for generating nitric oxide in your skin, and
Mhm.
nitric oxide is a vasodilator, so that'll help enrich the blood supply in the deeper tissues. And those blue wavelengths are very good at deactivating pathogens because they've got enough energy there to be absorbed by the protein of the virus, the fungus, or the bacterium, and it can switch off that pathogen. And so, for the treatment, say, of some skin disorders like acne and things, and dermatologists use shorter wavelengths, and they use ultraviolet or blue wavelengths specifically for that reason. So there are advantages and disadvantages, but the issue is you have to understand what it is that you're doing, as opposed to just willy-nilly pointing at all the mixed wavelengths. There is a selection process which you can, when you understand what these different wavelengths can do, which you can then start to select which effects am I trying to achieve, and
Yeah,
then
I think most of what's going on right now in some of these devices is in the willy-nilly category, squarely in the willy-nilly category, rather than is being done in a very targeted and precise way for a specific purpose. I think, to be honest with you, I think most of it is just marketing gimmicks to say, our device has X number of wavelengths more than such and such other device.
Yeah, well, I mean, to be fair, there is the potential with something which could be clinician prescribed to a patient
Yes.
for some of these other wavelengths, and for instance, blue wavelengths used together with curcumin, which is basically a turmeric
Yeah.
extract. That's a photosensitizer, and the
I've
blue
seen it
wavelength.
used in PDT,
Yeah, that's right. And that's
in
antibacterial
photodynamic therapy.
therapy,
Yeah.
and so if you've got someone
Right.
who's got persistent infection with a multi-drug resistant bug, then that
Yeah.
could be really useful. And you could be prescribed an LED of that bright. So I wouldn't say these things are useless, but the way that they're marketed at the moment, I quite agree with you.
Yeah,
It's
to be clear, I'm not talking about, specific devices used in a specific medical context. I'm talking about, the devices for the general consumer that just with some vague notion that sort of more wavelengths is better and having some blue LED interspersed in there is, better than not
absolutely.
having them.
Absolutely. And so when I'm starting to think about my clinical dentistry, I'm thinking, well, am I trying to stimulate things or am I trying to inhibit them? Or am I
Mhm.
trying to do both? Right. And so for some things, definitely. I just want to keep the dissymmetry lower. So then I'm stimulating fibroblasts and osteoblasts and all the other tissues associated with the healing of the things that I'm doing, or and higher dissymmetry, I may be trying to inhibit pain, or I may be trying to do both, which is confusing. So hang on to that thought because you can get two for one effects, a bit like I was talking about earlier in dealing with when I'm doing surgery. So I'll just cut through these videos. So when you're thinking about a 3D effect, you're looking at a volumetric system, right? Now, this is one of the things that I really seriously critique in my thesis is this concept of 2D planar dissymmetry, right? So much of what's been done in the literature is based on tissue culture and small animal studies, right? And out of that have been given grand pronouncements in regards to dissymmetry and harmful effects and beneficial effects and what have you. Whereas in a large mammal like a person, you've got some volume to consider. So your target might be at a distance away from the surface. So in order to reach that, you're going to deliver a higher dose, and which might be an inhibitory dose, but you need to do that safely within the parameters that we've devised, adopting strategies in order to help avoid overheating superficial tissues. Now, that may coincide with where you've got a wound where at the surface it's painful and there may be some pathogens, and that higher dose can both inhibit pain as well as deactivate the pathogens. Whereas at depth, you're stimulating the wound base and you're starting to get healing repair. So when you start to think of it in 3 dimensions, this whole concept of dose as joules per square centimeter starts to get a bit twisted, because I mean you're thinking about delivery of the dose at depth, but then there's layers and you can have multiple effects happening simultaneously. And so this is where you can start to be quite creative in terms of your application, particularly if you've got a superficial problem. So when you're thinking about pain relief, well, you can get pain relief at really low dosimetry, or you can get pain relief at really high dosimetry. So I then asked myself, well, how does this thing work? And it's what I regard as a Janus effect. And of course, Janus is the god with two faces, and as on the lower end of it, the effect of low dosimetry is to increase the resistance of the cell to stress, as well as promoting good blood flow there, because you get some vasodilatation, you're getting an enriched blood supply. The cells are in an oxidative cycle of metabolism. So that basically means, as opposed to having an acidic cell, it's producing lots and lots of ATP. I mean, take this for a figure that I picked out in the literature, Ari. I was reading from a really great paper when I was in the gym this morning, the way that you do. I was reading a scientific paper, aren't I, Sam? And it was from a lovely Italian researcher at Cambridge University, and she came up with something related to the generation of ATP. And she said each day the average adult produces 70 kilograms of ATP. 70 kilograms? I nearly fell off my exercise bike when I read that. I thought that's phenomenal. What a huge amount of product it's producing. It just goes to show how busy those mitochondria are in producing energy. But when they're in an oxidative cycle metabolism, it's producing maybe 30 to 32 molecules of ATP per glucose. Whereas if it's poorly perfused and you've got an acidic cycle of anaerobic metabolism, you're only going to get maybe 2 to 4 molecules of ATP, which is a step order of difference. If there's lots of ATP there, you've got a really vigorous active cell, which is going to be hugely active in producing matrix. The immune system is going to be really vigilant. It's really going to go for those pathogens, and and so a lot of good things can happen on low dosimetry. Now, associated with that can be a reduction of some of the mediators which cause pain, because pain is associated with inflammation. And if you're doing something which is an anti-inflammatory, and low dosimetry can be anti-inflammatory, you can have specific activation of anti-inflammatory gene transcription sequences. So the cell moves away from this acute inflammation and towards a resolution of matrix production cycle. Then that's associated with a reduction in pain, because the mediators of pain, like histamine, like bradykinin, like calcitonin gene-related peptide, like substance P, along with a whole bunch of other stuff which I could mention, these are all being suppressed. COX-2, the site of production for prostaglandin E2, is suppressed. And so you're getting less of these pro-inflammatory factors. So low dosimetry is going to be helpful for pain relief. But at higher dosimetry, you're starting to produce basically a nerve block. You can put the cell basically to sleep. So then it's the axon, the nerve fiber, shuts down activity. The mitochondria basically are turned off. There's no ATP there. And so when it comes to trying to activate that axon so that you get a wave of depolarization, you get this transmission of the pain signal along the fiber, is blocked. And so higher dosimetry, you can produce a selective nerve block, which is terrific, particularly in some chronic pain conditions, and that can be lasting. Plus, it also stimulates a protective sequence, which is what we refer to as hormesis. And these hormetic effects don't just protect the cell at the time from the stressor, because the cell's being really stressed by this higher intensity PBM irradiation. It also encourages the production of materials like heat shock proteins, as well as some stuff called ATF4, as well as activating various gene sequences, which then, should that event happen again, will then increase the resistance of the cell to the shock. It becomes more robust. And so it's preconditioning the cell. So preconditioning can work either at low dosimetry or higher dosimetry, but preconditioning is another benefit of an inhibitory dose, because the stress event, the stressor, is triggering the production of things which just help the cell survive should this occasion happen in future. So when you're looking at pain relief, it can be both ends of the spectrum. For my money, if I'm wanting to block pain, I'm going to use a laser. Every time I'll use a laser. It's a more intense source. I can more easily deliver photons to the depth of the nerve, whereas it'll take longer and maybe associated with an extended treatment time and maybe a less beneficial effect than those associated with some of the wavelengths of lasers I'm using. That's not to say you can't get pain relief with an LED. It's just for pain relief, lasers I think have got a great place if you've got access to them. If you haven't, you can certainly use an LED. It's just then you may take you a lot longer to start to achieve the sort of results that you're wanting, and it may be a less marked event. I mean, I can get a patient who's in pain, like the guy in the picture. I can fire a laser at it and I can switch that pain off inside of 2 to 3 minutes. Whereas with an LED, you can work at it away for a while with an LED, and eventually you'll get some vasodilatation, you get some benefits that will happen. It just takes an awful lot longer and it's a less marked event. And the big question there is, how long will that effect benefit the patient? Is it just a temporary effect, or is it going to be more lasting? And this is one of the big questions associated with analgesia, which I know people like Juanita Anders and various other groups in Australia, for instance, are investigating. So we're still learning. Okay, so let's talk about preconditioning. So one of the interests I have is in cancer care. Now, cancer's a plague, I mean, we all know someone who's had cancer. It's 50% of us, one time or other, get cancer, which is a seriously frightening figure, isn't it? And so we all witness friends and partners and relatives who go through cancer treatments, which can include chemotherapy and radiotherapy, which can have some really unfortunate side effects, because along the way of killing the cancer, it can disrupt healing and you can end up with some painful conditions like oral mucositis, or a radiation-induced inflammation of the skin called radiodermatitis, or you can have effects on the nervous system where you can get lasting nerve damage called neuropathy and what have you. And so there's been a lot of interest from the cancer community in how we can best use PBM in order to help these patients, both to heal as well as to prevent it. So I did a paper on this with colleagues investigating this, because this for me was an interesting model for dosimetry. And what I found was that the most effective intervention was to prevent it in the first place. And if on the day the patients were going in for their chemo, their radiotherapy, if they pre-treated themselves first, then the incidence and the severity of things like that horrible picture there, where this patient's got a really bad ulceration associated with chemo, it's not quite eliminated, but more or less, it's very low grade, and that was a very strong event. It was a statistically very powerful, the supported outcome of my research. Whereas if you've got somebody who's in pain, like the person in the picture, if you step up the dose, then you can then start to inhibit pain, but that's not going to necessarily promote healing and repair. It'll inhibit pain. So then you might need to inhibit the pain, but then step the dose down later on after you've done a treatment or two to start to get onto the sort of level of dissymmetry associated with healing. So I came up with this kind of little algorithm, and you could apply that to anything. It's not just for cancer care. And so the philosophy of care there is prevention is really the best thing to do. And if you've got pain, then do a higher dose. And for something which is a surface condition like this, 10 to 15 joules per square centimeter is a good dose to go for, or higher. And for healing, when you're no longer in pain and you want it to stimulate healing repair, step the dose down to about 2 to 5 joules per square centimeter, and then you're going to get good wound resolution. Now, I don't see any reason why people can't treat themselves at home, because I mean the availability of PBM in cancer care is really poor at the minute. There are very few specialist centres that have got that kind of equipment and access to equipment, and so people are enduring these sort of conditions where I can see no sound reason why they shouldn't be self-treating, and this is the sort of thing where you could really use these little LED torches to good effect, because you're not going to stimulate the cancer, you're not going to cause any damage, and one thing you can do is maybe help yourself, and with things like this can be very, very deeply unpleasant. It can be extremely painful. The studies on this condition, oral mucositis, show one of the things that people are most frightened of is oral mucositis because of the discomfort that it causes them. So enough said. So when you're thinking about using it for things like cancer care, yeah, this is more specialist. I mean, sure, it would be good to be able to have this under the direction of someone who's really au fait with this as a subject. But there are distinct benefits, and I think this is something very much for the future. Because I mean, this is where maybe a good dental therapist inside of a dental practice and general dental practice can do it. I mean, the pictures on the top on the right are of a patient who came in to see her hygienist in London, who contacted me and saying, "Hey, Mark, what do I do to help this patient with her oral mucositis? She's having chemotherapy." So I told her, I gave her that little treatment wheel, and she did it, and she can see the wound resolution going through that cycle. And subsequently, she treated them on a regular basis before they had the chemotherapy using her equipment, and the incidence and the severity of the later in the later rounds of chemotherapy was virtually zero. So I think this is something which is quite exciting from my professional point of view. And in terms of inducting people more generally, this is definitely something for the future. This is where self-help really can help, because it's one of those areas where it's such a common problem. So I actually did a webinar on it, and so if you want to watch a webinar on it, there's a link. And I spent an hour talking about cancer and cancer care. So we showed you this picture earlier of this child, and so it's got a lot of inflammation. There's pain, there's surface infection, and so I recommended that he used a fairly high dose at the surface, in looking at 50 joules per square centimeter at the surface, in order to suppress the inflammation and the pain. But because of the attenuation, and this is of the loss of energy through to the wound bed, this was also having this additional effect of stimulation, and that was done every day over a period of about 6 days, and you can see the progression of the wound resolution. So for burns, it works great. This is a child who had an incident with a dog. The dog injured them, And you can see that the local hospital had sutured it. There was a lot of swelling and inflammation associated with it. And understandably, the mother was very upset because this is her gorgeous 3-year-old, who's got this awful injury. So this is another student of mine in Belgium, Charlotte, contacted me saying, "What do I do?" And it was the same process. And over a period of about a month, she was doing very regular treatments, again, starting off in high dosimetry. And then later on, at about 10 days, when the acute inflammation subsided, we then very much reduced the dose in order then to stimulate healing and repair. And you can see the onward progress over 20 days to what's coming to some very nice wound resolution in that case. Um, it works on nerves too. So if you've got people who've got nerve damage, this can be helpful. But this is more for sort of lasers and sort of stuff that we dentists would do. But just be aware that there are people who've been left permanently numb following surgery, to say have a dental implant and being told, sorry, it'll never come back again. But that's not true. We've got cases now where we're actually encouraging and regenerating nerves that have been severed years before. And so I think this is a very exciting application, very much under research, but we've got some clinical cases that indicate it can work. So last summer, I was at the WALT meeting, World Association of Photobiomodulation meeting in London. And there I am with my friend Stephen Parker, who's my co-director of the training academy I run, and quite an eminent professor, with Juanita Anders, who's in the Armed Forces University in the States, who's got a great interest in the treatment of injuries associated with armed forces personnel, and myself. And we were listening to an awful lot of presentations about lasers and LEDs and all the rest of it. And so the question that we posed was, well, what's the difference between a laser and LED? Can LEDs work, and can these be effective? Because, as you know, the majority of the research that's been done has been about lasers rather than LEDs. And so there's a huge literature about lasers and their benefits, but unfortunately these aren't accessible to the public except for really low dose ones, which are not much use, whereas LEDs are optically a lot safer. And so there's all sorts of pros and cons that we have to consider in regards to the ability of different sources to be able to deliver energy to depth, as well as the safety factors. And of course, lasers are very much more expensive than LEDs. I mean, LEDs are relatively inexpensive, and maybe these are sort of things that are good for patients to self-deliver. And so there are all sorts of devices. I mean, the guy in the picture there is actually my brother-in-law in France, who's self-administering some PBM because he's tired, and he's wanting to improve his cerebral performance, bless him. But as he gets a lot of headaches, Christian's, well, he might. Um,
Looks like while he's on an important business call there.
oh, he's two for one. Oh, he's a great character. I mean,
Maybe I could try that. I have one of those devices, the same device right next to me. Maybe I'll try it.
you need both. And then there are little torchlight devices as well, which are less expensive, but they have got much smaller footprint and they're quite poor build quality, but do possibly offer some potential. So I did a study on this, looking to see what they could do. And my conclusion was that with LEDs, it really is not going to get deep into the tissues, because although you can see these visible effects, you're down to microwatts. You're down to some tens or single figure millionths of a watt at a distance. Whereas with a laser, because it's a more focused beam, and because of this nature of how the energy is behaving as it enters the tissues, you end up with images like that, where you can, there's almost like little stiletto needles with a small probe that should be reaching very deep into the tissue, but without much lateral scatter. Whereas with the LEDs, particularly if they're overlapping, which is what you were referring to earlier, you can then start to produce quite an even mat of energy. And these overlapping beams can then produce a fairly dense layer of photons at the dermal epidermal boundary. So you can get quite a rich layer of photons there, which would appear, if you got a large enough LED area, to produce some therapeutic effects. Whereas if you've got a really big single point laser with a powerful professional high energy PBM device, then you got a tool where you can really start to reach very deeply into the tissues, to reach that damaged tendon and what have you without too much trouble, with a more focused response. So the um, uh, the study
Hold
that
on one second, Dr.
yeah,
Cronshaw. I want to ask you on this slide, this seems to not match up well with, for example, Tom Kerber's
yeah,
penetration
yeah, yeah.
research,
Uh-huh.
where I think two key points. Number one, the way that you're sort of illustrating the lasers light as penetrating tissue,
Hmm.
it's remaining very focused and even actually getting narrower,
Yep.
whereas was that it scatters and diffuses once in the tissue,
Hmm.
so it doesn't necessarily retain those characteristics. I know this also is relevant to a point you brought up from, I forget the name of the researcher, but shining it through a piece of steak where it retained its sort of
Sure.
characteristics. But from at least the way Tom Kerber has done penetration depth study, he's even sort of shined a laser right
Hmm.
finger and kind of see the light diffusing.
Hmm.
So that's one point I want to flag here. And the second one is he's also compared lasers and LEDs of similar parameters. And I've seen a number of different tissue samples where he's done these tests, different wavelengths, and so on. And it shows very, very similar depth of penetration with laser and LED
Hmm.
at similar parameters. So
Yeah.
I'm curious what your thoughts on why is there a discrepancy, and maybe this also relates to how you designed this particular study.
Yeah, well, I mean, I've looked at some figures from Tom's study where he took some chicken breast and he irradiated it with some LEDs, and he was taking measurements, looking at the amount of energy that was penetrating down to 5 centimeters and then down to 7.5 centimeters using his LED, and he was detecting the presence of photons from his red wavelength laser. But when you actually looked at the energy associated with that, he was looking at around about zero point 0.4 to zero point 0.8 milliwatts. Okay, per square centimeter. Okay, now that means then to deliver 4 joules, that would take you just short of 2.5 to 3 hours to get it up to the sort of level where you might be producing a therapeutic effect. So yeah, you can deliver photons to depth using an LED, but the energy level that you're achieving at depth is going to be really low. And that then means that then your exposure time in order to achieve the therapeutic dose that you may need to get to trigger the event that you're seeking through PBM may take you an inordinately long time. And whereas with laser, it's a much more intense source. Because of the optic properties of the laser, the beam is quite tight. It doesn't tend to scatter to the same degree because the wavelengths are all within a very narrow spectral range. You're within a nanometer, and so all the photons are in the same phase in time, and they enter the tissues. And when they do scatter, they scatter forwards, and so you start to get these like needle-like appearances because those images at the bottom. They're of some using a device which is called a beam profilometer, which is a camera, and then there's a sample tissue. And down here, I'm either using an LED or I'm using a laser. And you can see the different patterns of energy distribution that's coming through the other side. Whereas with the laser with a small diameter probe, particularly it's a cluster, and there I've got a cluster of 200 milliwatt devices, you end up almost like the needles going into the tissues, unlike the LED where it's more diffuse. Whereas with the big source, there's more power in the middle of the beam, and then you're starting to deal with a bigger volume of tissues. So I think it all depends on the parametry, on what it is actually you're looking at. Because it's like comparing apples and bananas. I mean, you can. I wouldn't say you can make a banana look like an apple, but Tom will give it a good go. Bless him. But
Okay, so let me ask you one more point and this speaks to something you were just alluding to a moment ago as far as the parametry and the amount of energy at a given depth, and this relates to a controversy around irradiance.
Mhm.
And so, what is the role of irradiance in penetration depth?
Mhm.
And point important distinction here and sort of point of confusion
Mhm.
around the degree to which higher irradiance leads to quote unquote higher penetration depth
Yeah,
as defined by sort of the maximal depth of tissue where we could detect any photons
sure.
versus, I don't know if there's a proper term for this, but let's say effective penetration depth or something along those lines,
Yeah,
where we might define it by the amount of energy present at a given depth. So, as distinct make up numbers, let's say the maximal depth that light could reach is 5 centimeters or 8 centimeters that 600-meter light source could reach. And we could say, well, didn't cause any photons to be detectable
mhm.
below that 8 centimeters of depth. Therefore, irradiance has no real relationship to penetration depth. It failed to increase maximal penetration depth
Yeah.
with a 100 versus 300 milliwatt
Mhm.
per square centimeter device. There was no meaningful difference in that maximal penetration depth. But if you compared a difference in irradiance to, let's say, something below that maximal depth, let's say 3 centimeters, 2 centimeters, 3 centimeters of depth, there'd be a large difference amount of energy present at, let's say, 2 or 3 centimeters of depth with a low versus a high irradiance device.
Yeah.
You
Well,
follow the distinction I'm presenting here?
I do. And when it comes to irradiance, yeah, this is something which causes a lot of confusion. And irradiance is certainly related in regards to optical penetration to wavelength, because it's related to the size of the optic spot. And then there's also the issue of what we call the spectral beam profile, which is the energy distribution across that spot. So if you look at those images in the bottom, they're Gaussian beams where it's not an even energy distribution. Whereas with your LEDs, because it's got this big wide beam divergence angle, it doesn't come to that sharp spike in the middle. And that's going to affect the delivery of energy into deeper layers because there's a lot more energy in that middle third of the beam. And then because of this 1 over E effect, you're then delivering more energy to depth. Beyond about a centimeter, that doesn't really start to make an awful lot of difference because, for instance, some people buy devices which are gated, right? They switch them on and off, and they can have a period when they're on, which might only be less than 1% of the total time you're using the device. But when it's on, you might have 300 watts that's been delivered via that device. And so for a fraction of a second, which can be down to millionths of a second with some of these devices, or tens of thousandths of a second, you suddenly got 300 watts there, and then it's gone. And the argument is, well, this is going to drive photons deeper into the tissue. And so some on the bench studies had been done, not by me, by another group who used a similar model to myself. And what they found was that comparing the same um, average power, but at different peak powers, beyond about a centimeter, it made absolutely no difference whatsoever to the optic penetration. And so you can extrapolate from that to this kind of cutoff with your irradiance, where the benefit of increasing the irradiance eventually is going to be limited by the capacity of the photon because of its physical properties in relation to the tissues, because of scattering and absorption. Um, uh,
And to the wavelength,
Absolutely, which is also
like the relationship of the wavelength and the optical properties of the tissues themselves.
after which then it really is the whole thing kind of is limited. So when you start to think about delivering energy to considerable depth, this still poses a challenge, which is why they've been experimenting using catheters with a laser or an LED built into them in order to deliver it to close proximity to, say, spinal nerves and things like this in an effort to help overcome this problem. Um, but then, as we'll discuss later on, then there are other aspects related to PBM which are perhaps very much under discussed in the literature because when you start to think about the mechanisms, there's this incredible focus on photochemical reactions happening inside of mitochondria at a cellular level, but there's a whole deal more going on there, and it's what I refer to as bioenergetics or entrainment. And this is something that we'll progress to discuss to, if you wish, later in this presentation. Okay, so hopefully that's answered your question on irradiance. Is that okay, Ari? Are you happy at that point?
Can you just more directly speak to the distinction that I was bringing up? So the degree to which irradiance
Mhm.
affects maximal penetration depth versus like the effective dose of energy delivered at a depth of tissue that is more superficial than that maximal depth.
Yeah. Well, I mean, the issue with the radiance is when you've got a more intense source, which is what a radiance is. You're packing more photons into the area, and so it's a higher number of watts per square centimeter. Then the effect on the tissues is going to change, because beyond a certain level, you'll be changing the tissues quite profoundly. I mean, you can be heating things up, for instance, and so there's a sort of a cutoff. There's a limit to what you might be able to achieve by stepping up the irradiance, because you can then start to see some photothermal effects, which can start to change the characteristics of tissues. Now, biological tissues, when they're dealing with a living system, are very sensitive to temperature, and a little small rise. This is all good. It stimulates enzymic activity. Above that, then you see the cell go to sleep. It's like a protective stasis. Beyond that, then you can start to see progressive signs of tissue damage. And so, in response, the biology, because temperature is very strictly controlled by a cell, is intended to protect the viability of the cell and the tissue. So, initially, in response to a rising temperature, you see vasodilatation. So, blood vessels dilate, and there's a heat sink there as the bloodstream tries to diffuse away the heat from the surface. But when it gets above 46 degrees centigrade, as opposed to seeing vasodilatation, you see vasoconstriction. The blood vessels actually close down, and this confines that heat, because this is intended, I guess, if you're looking at it from this point of view, to reduce the collateral tissue damage and to confine it to a smaller area. And then you're starting to get into an area where you're going to get an ascending level of damage, because progressively, because the energy has been confined into that area, then you're going to get more and more and more damage to the point where you're going to get coagulation, and you start to see all sorts of adverse effects. So when you're looking at irradiance, you have to think about, well, okay, if you've got more power per square centimeter, this is increasing the potential for that concentration of photons, for more photons to be delivered to depth. But then in the superficial layers, we could then start to over-energize tissues and start to produce some harmful effects. And
And
those
this relates to some of the irradiance parameters we previously discussed in relationship to skin overheating.
and that
Uh,
is, again closely related to wavelength, and then
right.
also beyond a certain level, and here you're looking at most at 2 centimeters, but probably one that's 2 centimeters, it makes very little if any difference, because it's more to do with the physics and the optical properties of those particular wavelengths.
Sorry,
Rather
what makes little difference?
Well, beyond a certain depth, because of the very high irradiance you're applying at the surface, then you're starting to change the optical characteristics of the tissue, and that will then affect it. The research shows that if you heat things up, then this can then affect the refractive index of the tissues. And if you heat them up beyond a certain point, then you'll be increasing the both the scattering as well as the absorption coefficient, and then more energy will be absorbed in superficial layers, and then you're starting to get more damage up to the point where you see signs of hypothermia and dermatitis and all the bad stuff that you're trying to avoid.
Yeah.
So, um,
But
uh,
Dr. Cronshaw, let me present I think you're introducing a lot of layers of complexity, and I'm trying to present just a sort of a more simplistic scenario that I want you to speak to the role of irradiance in, and that is, let's say I'm trying to affect change in 2 centimeters of depth
Mhm.
with an 810 nanometer
Mhm.
wavelength.
Mhm.
What is the role of irradiance in influencing ability to deliver in effect to that 2 meters of depth?
Well, if you've got more power, then because of this 1 over V, 1 over E effect, there are more photons at a level beyond which you normally, by convention, think it was less than that 37% level. And up to a point, you'll then be better able to deliver that energy to depth. And
Mhm.
this then comes into the concept of total joules as opposed to irradiance, because I mean the total amount of energy you're delivering, that too can start to have an effect. But is that to do with penetration, or is that more of a systemic effect? So that's a different
Mhm.
issue. To answer
Right,
the question, I think really when it comes to irradiance, the cutoff with an 810 really is around about 500 milliwatts per square centimeter. And beyond that, then there is an ascending risk of starting to produce some photothermal effects. That's not to say that
right.
you can't have a large applicator, say one of these 4 centimeter diameter laser devices used by the physiotherapy community, where you might be putting in as much as 6.5 watts into that in order to fill that beam. But then then have to optically scan in order to avoid over-energizing the mid-third of the beam. And even then, at round about a sort of 2 centimeters at depth, the ability to start to drive those photons really deep, it's reduced. It's not an absolute. You could, like Tom Kerber showed with his little red LEDs, you'll still have photons getting very deep. It's just that the number of photons that's getting through is going to be remarkably small, and then it takes a very, very long time to get up to the kind of dosimetry that you need to produce the kind of changes that traditional PBM therapies recommend at a.
And that's where irradiance factors into this. So like you've mentioned the sort of the upper end of this, which we've touched on a number of times and we've discussed at depth in a previous conversation. The sort of that 500 milliwatt cutoff where you start to get so high in irradiance that you overheat the tissues. But on the other end, on the low end, let's say, there are a lot of devices like this on the market, these flexible, pad style devices. And many of these devices are 7, 10, maybe 15 or 20 milliwatts per square centimeter. Maybe I think the highest I've seen is maybe close to 30 milliwatts per square centimeter in this style of device. What with those kinds of irradiances, how does that factor into this picture of, let's say, trying to affect tissue at 2 centimeters of depth in my knee joint?
Well, I hate to depress you, but you're probably only going to be delivering something like 0.2 percent of surface energy
Hmm.
per centimeter of depth.
Right.
So being the case, if you've got a really low power device, then the number of milliwatts, it'll be not milliwatts, it'll be microwatts, it'll be millionths of a watt. And that then means that the treatment time is very, very extended in order to produce it. Now, when it comes to things like wearables, perhaps that's a way of going about it, or um, repeated exposure over a number of sessions during the day, where cumulatively you may be able to achieve that threshold. But it is going to take
Meaning,
hours.
meaning, if the irradiance is so low, basically you have to compensate by massively expanding
Yeah.
the duration of treatment. So with that low of irradiance device, you're saying essentially you would have to make it into a wearable. You'd have to wear it for hours, something along those lines. Is that what you're saying?
Yeah, I mean, there's a study by Shen, for instance, who was looking in tissue culture, using some fiber optic impregnated materials. And he was showing activation of fibroblasts to produce collagen when he had an exposure time of just short of 6 hours. And that was around about 0.25 of a milliwatt, so very, very low levels of power. Yet for hours and hours and hours and hours, eventually he kind of got there. But that's in tissue culture. And so when you start looking at the human body and its complexities, it would take a long, long, long time to get to those sort of levels. And so then you have to think about, well, maybe there are other effects that are happening here. Because I'm not saying to you things like that can't help. It's just it might not be working in the pathway that you think. Okay. And this is where I think there's been a paradigm shift which is emerging in the PBM community, where we're starting to think about different processes operating simultaneously to produce it. This is this concept of bioenergetics and what I call entrainment. This is where we're introducing energy into an energized biological system, which is then like having a ripple effect on the organism, not just on the immediate target. Okay, so let's keep going, Ari, because this is a great conversation. Okay, so when I looked at these things, and some of them were better than others, and they certainly had potential, right? They're very crude devices. They're very basic. They're really inexpensive. They're widely on sale. Do they do what they say in the tin? Well, the consumer feedback was really positive on them, but how much of that was a photothermal effect and how much of it was PBM? I've got my doubts. But these are the sort of devices which we've got going out to undergo some clinical trials. And once we've defined some benefits, these may be the sort of things which in time, with some added bells and whistles, little minor tweaks to the design, could be something which might even be useful. At this stage, there's no harm in using them. You're certainly not going to do any harm, apart from maybe to your bank balance, but it may help you. On the other hand, it may not. Okay. But it certainly doesn't do the great things. I mean, these things are advertised as curing everything. It's only a little device, a little LED and bless, and people who are using them, if they're really assiduous, it can produce some clinical benefits. But as I say, how much of that's photothermal and how much of that is PBM, I've got my doubts. So can things like LEDs work? I mean, there's a lot of flat panel systems out there, and this is from a medical device made by a company in Switzerland called the ATP 38, which has been adopted by some world-leading oncologists in France. They're using this to treat conditions like neuropathy, which is nerve damage associated with chemotherapy, as well as in radiodermatitis and stuff. And I listened to presentations on this at Walt in London, and the sort of irradiance that they're using there was 20 milliwatts per square centimeter using a near infrared and 840 nanometer LED. They reckon that at about 2 millimeters to the dermis, they're around about at a milliwatt per square centimeter. And I thought, well, that's just nothing. I mean, that in order to get it up to 5 joules, it's going to take you a long time, and that's an extended treatment time. And yet they've got quite large areas and they seem to be producing some interesting effects. I mean, this is a guy who's got some radiodermatitis, he's got a burn basically generated by the radiotherapy that's been applied to treat his throat cancer. That's been treated using this exact device, and it's produced a great effect. It's produced really good resolution of the inflammation and very good wound healing in the hands of Professor Bonzadun, who's a world leading authority on this. So then I had to start to rethink a lot of the things that I thought I knew, because up to this point, I really was a very strong fan of laser, laser, laser. If you want to reach depth, use the laser. And I thought, well, these things clearly can work. How is that possible? And so I went right back to basics and I thought, well, what is actually happening when you put a photon into tissue? And there's a variety of effects that can occur. It can be the emphasis in literature is on this photochemical effect, where unit 4 of the electron transport chain is booting the cell to produce more ATP. But then there are also some photothermal effects, even though Praveen would probably decry that, but there are undoubtedly some low-level photothermal effects, and maybe the higher-level photothermal effects can be beneficial. There's also a photoelectric effect, and Einstein got his um, his Nobel Prize, not for the special theory of relativity, it's because it was for basically the essence of solar PV. He was shining bright light onto aluminium and it was generating electricity. The light was stimulating electrical flow. And in PBM, you are going to get some photoelectric effects because some of the things that you're exposing are metals. When you expose those metals, you get a release of electrons, and that can then be a catalyst. You can get some photofluorescent effects where the energy is absorbed and then it's re-emitted. And this is something we definitely see in nature. You can see both fluorescence as well as phosphorescence. And the marine animals that use this as type of signaling, and there are certain marine algae where at night you see this really weird greenish glow in the sea. As the waves break, you see little bright flashes. It's extraordinary. This is a photofluorescent effect where the light during the day is being re-emitted as little packets of energy. And perhaps this is another pathway, as I'll discuss later, which may be associated with PBM. Then you can get some photomechanical effects where it creates like a shock wave. And that shock wave then shakes open the iron gate, a little bit like when you clap your hands, you can feel the vibration in the air, and that can be transmitted through to the tissues. And then there's some photomagnetic effects. And so this is where things which contain ferrous compounds, you can start to realign the dipoles, and that can change the configuration of the enzymes. So there are all these different pathways, all right? So rather than thinking simply of photochemistry and that photon producing ATP at unit 4, when you start to think about all this multiple effects and all the different constituents of the cells, then it's a multiplanar thing. Now, in the skin, you've got certain cell types which include keratinocytes, and they produce the squames that form the keratin, which is the outer layer of your skin. And there are also some little cells called melanocytes. And melanocytes are the things which produce pigment when you're exposed to light, which is melanin. But also, they produce a whole load of other biologically very active things. And so in skin, it's been suggested this is almost like another brain, because there is a neuroendocrine axis where by exposure of skin, you can start to produce some quite um, um, important increases in production of neurotransmitters like serotonin, noradrenaline, dopamine, as well as a whole bunch of very important hormones like growth hormone and adrenocorticotrophic hormone and prolactin and things like this, which can peak at some hours. So the skin isn't just a sort of an inert wrapper around the tissues. The skin itself is production of all sorts of steroids. It's the site where with UV you get the manufacture of vitamin D. And it's quite a dynamic organism where there's a correspondence between the skin and the central nervous system in both directions. It's not just got sensors to detect pressure and temperature and pain and things like this. It's also yeah, it's a two-way process. It's reporting back to the CNS, and the CNS is also responding to some of the products produced inside of skin. And these things are all photo products, and so when you expose the skin to light, it can start to produce all these very important biologically active substances, and this is happening right at superficial layers of your skin. So, I mean, serotonin is, this is something which affects mood, and anybody who's suffered from depression, they're given serotonin uptake inhibitors, to elevate their CNS serotonin levels. And a bright sunny day, you feel good, and there's a reason for this. Noradrenaline, this is the sort of the fear, fright, and flight thing. It's the thing that gives you the go, 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 as it were, and this is another neurotransmitter which just changes mood. And as for dopamine, well, this is the thing which is associated with motivation and reward and addiction and things. So these things are producing a systemic effect. And as for these hormones, each of these hormones again produces a systemic effect. So this is where by irradiating the skin, maybe with a big flat panel or with a larger LED, you may be doing a little bit more than you realize, because it's not just the tissue that you're exposing. You may also then start to trigger off the generation of some appreciable levels of some quite powerful systemic agents, which can affect your brain as well as your endocrine system. And this is then producing distant effects. because often illness isn't something which is just associated with a specific area. It can be associated with systemic conditions, and people who've got inflammation are more prone to Alzheimer's and things like this. So there's a question really about should you be targeting the particular area where there's the problem, or should you be treating the whole person? And this is I think, a concept which I think is quite useful, particularly in regards to LEDs, because you have these LED impregnated mats like yoga mats, and then you've got much more expensive LED pods where you can do full body irradiation using red and near infrared wavelengths. And these can be producing some quite profound physiological effects, which are recognized to be treating very unpleasant conditions like fibromyalgia, for instance, even though in theory the photons that are reaching those deep levels of the muscle after 20, 30 minutes inside the pod is really quite low, it is producing something which is clinically of benefit. And so maybe it's through these systemic effects it's been mediated in part. We don't know. So
Dr. Cronshaw, I think I'm pretty close to out of time here. I think it sounds like maybe we'll have to continue the rest of this in another session.
we're about 3 minutes away from the end.
Are you? Okay, great.
So I'm going to round
I do want to quickly mention, I don't know if you saw the 2022 review on the serotonin deficit theory of depression
yeah.
and the idea that serotonin, the idea that SSRIs work to combat depression based on increasing serotonin levels. Most of that has largely been debunked, and it's what's really interesting about it is that there was like 30 years of research based on this idea that serotonin is the thing that controls our happiness.
Mhm.
And I don't know how many hundreds of billions of dollars invested into drug development, all based on that. And then like 30 years later, they're like, actually, there's no real evidence to show that it's a serotonin deficit. But I'm just saying this as a random sort of point here, but there's no question that serotonin does stuff in human physiology, that it clearly has major roles. But just as an interesting aside, the kind of serotonin hypothesis of depression has largely been debunked at this point.
Yeah, well, I mean, the treatment of depression with PBM is one of the active areas of research, and so I would suggest that it is maybe being mediated through neurotransmitters. When it comes
Yeah.
to SSRIs, which are drugs which are intended to slow down the metabolism of serotonin and retain higher levels, these drugs, I could well believe, are working at a level equivalent maybe to a placebo, maybe to a 30% event effect. And
Yeah, there's a lot of research. I'm forgetting the name of that researcher. There's a well-known depression researcher who's done a ton of research where they've compared the effects of SSRIs versus placebos. But anyway, I could look. But go ahead. Sorry to interrupt.
so just to conclude my thought, and because there's a lot more we can say about this. If you start to take a larger frame, look through the other end of the telescope and look at the whole person. And if you're thinking about introducing energy, then the photon, it's an electromagnetic field. We're full of electromagnetic fields. All biomolecules have got an electromagnetic field, and these can resonate. And if they resonate and they're on the same resonance frequency, they can vibrate together, or they can amplify, so you're getting a more profound effect, or they can even tune each other, so that external source then can start to reset the physiology of the cell. So, in terms of health and disease, in the disease state, you may have misfunctioning sequences of enzymes and things which you can then reset. A little bit like, if you have a coronary and then they come along, with the pads, and they put an electric shock across your chest, and then resets the the firing electrical signal that starts your heart pumping back into sequence again. At a less dramatic level, maybe this is what PBM is doing. It's harmonizing the physiology of the cell back to a healthier bioresonance. And
Yeah.
I think when you're thinking about bioenergetics, this is where we're all very much full of elements which may then be resonating. So it might not just be a chemical event, it may also be associated with bioenergetics. And I think at that point we'll call it the draw, because we've covered such a lot of territory area. I hope we've not completely exhausted your poor listeners. We've got so much more we could talk about, but we can
Yeah.
pick the story up on another day.
Do you want to complete the last bit of your presentation here?
Well,
Or do you want to do
I
it on
don't know
another day?
how far we
We
go.
still have, there's still plenty to
I've
talk
got
about. I
maybe,
still
yeah,
have lots of
I've
questions.
got a couple of slides. Yeah, I'll finish
Okay.
up. So the
And for anybody interested in the researcher I was mentioning, his name is Dr. Irving Kirsch.
uh
The last name is Karschch. He's done a ton of research on antidepressant drugs and well worth looking at his research.
So what I was just going to finish was really looking at some light sensitive targets, which are present in all of us, whether it's at the surface or at depth. And as opposed to it just being specific enzymes, there are pigmented materials which are broadband acceptors of photons. There are metals present in enzymes, such as heme groups and cuprous groups, copper groups, which are present in all sorts of key enzymes which are photosensitive. And then there are specific clusters of such as cytochromes, such as there can be TRPVs in the outer membrane of the cell, which are all photosensitive. And these enzyme clusters can then start to activate ion gates to open and to close. Some of these are associated with important ion channels, so calcium, sodium, potassium, which can affect things like transmission of pain, as well as redirecting the physiology of the cell towards a different pathway. And then there's this intriguing possibility that also nerves themselves may actually be able to act in order to be conduits, to be like a passage of a pathway of transmitting photons into the cell body of the axon, maybe into deep tissues, which is, we know this happens with naturally occurring biophotons, which are almost like quantum effects, tiny and minuscule amounts of energy released through fluorescence within the mitochondria, which then gets carried along this outer sheath of the nerve down to the cell body. But maybe when we put an extrinsic light source on the outside of these myelinated nerves, maybe then some of those photons are being transmitted down the myelin. We don't know, and so this could be a hidden pathway. I mean, I was reading a paper over the weekend where somebody was using a 50 milliwatt laser device for doing laser acupuncture to treat kids with autism. And he was applying one joule, just on a couple of acupuncture points. They were producing effects which were clinical effects, improving the behavior and the ability of these children to cope. So I thought, well, how's this working? Well, maybe this is one of the pathways. Well, there's a lot that we don't know. Um, as for this concept of skin being a mediator, well, apart from keratinocytes and melanocytes, hair, that may also be an optic pathway where light can pass down the hair shaft to the hair bulb, which is very richly innervated. And then there are a variety of other effects. So these photothermal effects, forgive me, Praveen, but I mean, low-level photothermal effects inside of the cell, as well as more tangible effects inside of a tissue at a low level, can be beneficial to stimulate metabolism. At a higher level, but below the threshold necessary to start to lead to damage, these can be associated with pain relief. And I think it's worth considering temperature effects, because you can heat things up at the surface, as I've discovered from my studies, and at 2 to 3 centimeters in depth, you can detect a rise in temperature. So even though the photons might not be getting through to depth, you may then be acting temperature sensitive ion gates like TRPVs at depth. And is that photobiomodulation, or is it a photothermal effect? Who cares? It's starting to turn into a semantic argument. I mean, I think that it's just there's a panoply, there's a multiple series of things that are all happening simultaneously. It's not just one event. I think at
Yeah,
that.
I think that's what you presented here and on the last slide as well, if you could go back to that one for a second,
Yeah, sure.
the previous one.
Ah, yeah, there you go.
I think what this is presenting here is just a vastly more expansive picture of the way that photons interact with human biology, as compared to the sort of the old school conception of photobiomodulation as being purely a photochemical reaction involving cytochrome C oxidase in the mitochondria and sort of photons of light, sort of mechanically triggering CCO and then having this effect based on that. I think what we can see from this, and I would guess, and I suspect you'd agree with me, that we're probably still in our adolescence as far as understanding all of these different layers of human physiology that are in fact sensitive and affected by light. And I think it would be interesting to revisit this, 10 or 20 or 30 years from now, because we'd probably find that this list of a dozen things
Mhm.
is probably 100 things, 100 different ways we've discovered that different photons and different wavelengths of light are interacting with and triggering different mechanisms in human physiology.
Absolutely, because I mean, some of these photosensors are deep inside of organs, way away from the light. Why? Nature abhors redundancy, and yet
Mm-hmm.
it's quite complex. Photosensitive things, opsins and things, which are present in the heart and various other key important organs, far removed from anything which you might reasonably be able to expose from a surface application. And yet the photo optic switch is there. So there's a lot, I think, of hidden mechanisms here, which are natural mechanisms, maybe to do with biophotons and we may a little bit like cable, we may not be activated by light pathways. We don't know, and that's exciting that we don't know because these are areas that we can investigate and see how we can best use them
Yeah,
therapeutically. But what we
yeah,
do know is sufficient to be able to start to produce some quite exciting effects, even with simple devices like at home use LEDs and things. But we've got a journey ahead of us, and it's far from exhaustively researched by any means.
yeah,
So just to wrap it up, if you've got something on the surface and you want to stimulate it, I suggest, 2 to 5 joules per square centimeter is good. If it's deeper, step up the dose by a factor of 10. And then you'll stand a chance to be able to get down to that kind of threshold level. If you're trying to treat pain at the surface, like that painful ulcer associated with chemotherapy, 10 to 15 joules per square centimeter. But if it's a deeper structure, then it's a very high dose indeed before you be able to deliver those sorts of energies, and that's not something you're easily going to manage using a home device LED, one form or another. And if you're using a laser, remember it's a Gaussian beam, so keep it moving, otherwise you're going to end up overheating the tissues. And so that was my summary. If you got a big applicator, you'll be dealing with a big volume, not just at the surface. Watch out for the Gaussian effects of the laser and make sure you move, otherwise you'll end up overheating things. When you're looking at selection of wavelengths, there's a good conversation we can have there about some of the mythology associated with this to do with pigments and blood and water. So maybe that's a conversation for another day, Ari.
yeah. We hinted at your skepticism of the optical window, so I flagged that as something that I wanted to dig into with you.
And then there's
That can be another day.
the issue to do with the timing of the intervention. Is this to prevent something or is it to treat it? Because sometimes it's better to prevent something than to treat it. And when it comes to producing analgesia, I'd suggest that the indication is that higher dosimetry is the way to go. But be aware that there can be some 3D effects, and also start to think in terms more globally of what you're doing to the organism, because it is a bioenergetic system, and you'll be affecting localized, regional, as well as systemic effects, which will be mediated either through the innovation or through the endocrine system. And so it's a much more compound paradigm than simply firing that sort of billion ball photon at unit 4 of the electron transport chain. We've moved a long way since then. Anyway, so here I'm with a couple of my friends that I did my doctorate with at one of our congresses. You can see that it's a very enthusiastic group that we've got going at the Montfort, and we each of us are on the same pathway to try and make it successful. So thanks for your time, Harry. I hope it's been of some benefit to you. At such time as you wish, I'm very happy to speak with you again. And we've gone through an awful lot of materials tonight, so I think we'll both sleep well, or I hope you do as well as I will. And we'll no doubt be speaking again soon.
Yeah, sounds great. I certainly have many more questions for you, and I look forward to digging into that. This was a wonderful presentation. Thank you so much, Dr. Cronshaw.
It's been very much my pleasure, and thank you to everybody who's had the patience to go the journey. All right, so thanks again. All right, cheerio now. Okay, bye bye.